Hello everyone, I hope you're having a good day. Today's topic is about cystic fibrosis, a common pediatrics disease that we should all be familiar with. Now, in the introduction, we should know that cystic fibrosis is a multisystemic disease, and it is a disease of the exocrine glands. Epidemiology. It is the most common genetic fetal disease in Caucasians, and around 70,000 people are affected in the world. Now, let's talk a little about genetics. We have something called the cystic fibrosis transmembrane regulator protein. This protein is present on chromosome 7. Now, this protein maintains appropriate composition of fluids and salts within secretions, and it transfers chloride outside the cells. Now, in cystic fibrosis, we have a mutation in the gene responsible for cystic fibrosis transmembrane regulator protein, and this mutation of course will be on chromosome 7. The most common mutation that we should all know is delta F508. It is an autosomal recessive disease, and when this mutation is present, bicarbonate and chloride will be stuck in a cell, leading to dehydration of airway secretions, and this leads to viscous secretions in the airways, which will lead to airway obstruction, and as we know, obstruction will lead to colonization with microorganisms. Now, the most common microorganisms that we should know on cystic fibrosis is Pseudomonas aeruginosa and Staph aureus. Now, the clinical picture of cystic fibrosis is it is a multisystemic disease, so it will affect multi-organs such as the lungs, the pancreas, the liver, and the intestines, and more systems. Now, how do these patients present? In the neonatal period, they will have something called meconium ileus. Now, because they have thick, viscous meconium, this will lead to the blockage of the ileum, and the obstruction will lead to failure to pass meconium in the first 48 hours of life, and vomiting, and also abdominal distension. Also, these neonates will have a salty taste skin. So, mothers may complain that when they kiss their children, they feel that they have a salty taste. Now, they will also have something called Pseudo-Barter's syndrome, which is low potassium and chloride, to something we know called metabolic alkalosis. Now, in the infants and childhood, the presentation will be as following. First, in the respiratory system, we'll have recurrent chest infections, and as we said, the most common microorganisms that we should be familiar with is Staph A and Pseudomonas aeruginosa. And they will also have recurrent wheezy chest, sinusitis, polyps, and a phenomenon we should know that's called allergic bronchopulmonary aspergillosis syndrome, and this is treated by steroids and antifungal medications. Now, they also present with pancreatic insufficiency, and we all know that the pancreas is an exocrine and an endocrine gland. So, as the exocrine presentation is, it will lead to fat malabsorption, and this fat malabsorption will lead to hypoalbuminemia and steatorrhea, and eventually failure to thrive. As the endocrine gland of the pancreas, it will lead to glucose intolerance that will progress into diabetes mellitus. Now, for the gastrointestinal tract, it will present as, and these are later presentations, but presenting as portal hypertension, liver cirrhosis, distal obstruction, and cholestasis. Now, how will it affect the genitalia and the joints? Well, it will lead to male azoospermia, congenital absence of the vas deferens in the males. And in the females, it will lead to secondary amenorrhea and also abnormal secretions in the fallopian tube, which will lead to subfertility. It will also lead to arthritis in the joints and clubbing in the hands. Now, diagnostic tests we use. First of all, we may use newborn screening, which will show high immunoreactive trypsinogen. And we have something called the sweat chloride test, where we stimulate sweating by giving pilocarpine to the patient, as you see in the picture, which is represented as medicine. Now, the results. When we measure the salt content after sweat is collected, it will be positive if it is more than 60 millimoles per liter. It will be borderline if it's between 40 to 60 millimoles per liter, and it will be negative if it's less than 40 millimoles per liter. We may use the chest X-ray as a diagnostic tool which will show us pulmonary involvement. And we may have the stool examined, which will show us pancreatic insufficiency by showing us as decreased fecal elastase. Now, we may also order liver function tests. And there is something that we should not know much about, but we have to know that there's a test called bioelectrical potential differences across nasal epithelium. And if you see the picture, in B, there's a high difference. So this is how it will represent in cystic fibrosis patients. Now, how is cystic fibrosis diagnosed after the previous tests are done? Well, we have a criteria. First, one or more typical clinical features of cystic fibrosis have to be present, such as either pulmonary diseases, gastrointestinal involvement, salt loss, obstructive azoospermia, and 2 elevated sweat chloride tests, and only one of the following are needed. 2 mutations of cystic fibrosis by DNA analysis, the mutations we talked about, or ion transport across nasal epithelium abnormality, the one that we talked about previously. So, for the diagnosis, we need a typical clinical feature and 2 elevated sweat chloride tests and one of the following, either 2 mutations of cystic fibrosis by DNA analysis or ion transport across nasal epithelium abnormality. Now, how do we treat cystic fibrosis patients? Well, we have to know that it's a multifactorial treatment targeting mainly the pulmonary and the gastrointestinal systems. Okay, how do we treat the respiratory system? First of all, we need essential pulmonary physiotherapy. We need the usage of bronchodilators, and we have to use antibiotics. We can use these antibiotics as orally by giving them for prophylaxis, or we can use antibiotics as treatment if there is a present infection by giving them IV. We also need to use something called mucolytics, which lyses the mucus viscous secretions in the respiratory airway secretions by giving nebulizer acetylcysteine or recombinant DNAs 2 hours before physiotherapy. So, when we want to do physiotherapy, we can give recombinant DNAs 2 hours before. And we can use 7% hypertonic solution. For pancreatic insufficiency, we can treat it by giving enteric-coated pancreatic lipase and protease. Now, if we have high steatorrhea in the patient, we should not withhold fat in the diet, but we rather raise the dose of lipase. But we have an important fact that we need to know that lipase given should not exceed 2,500 units per kilogram, because more than that, fibrosing colonopathy may happen. Now, we can also give fat-soluble vitamins that we can use the mnemonic to memorize as CADE: vitamin K, vitamin A, vitamin D, and vitamin E. And we also need a high-calorie diet.